Hello, everyone, and welcome to our module on shock. So, the term shock refers to a life threatening fall in blood pressure. And anytime this happens, there's going to be poor perfusion of tissue beds, and that's because blood pressure is the driving force for blood flow. When there's poor perfusion of tissue beds, there's not going to be enough oxygen delivery to cells. So, cells are going to switch over to anaerobic metabolism. And whenever they do this, they produce lactate. And so an elevated serum lactate level is a hallmark of all forms of shock that we'll talk about in this video. It occurs because there's low blood pressure and therefore low blood flow and low oxygen delivery. Now, by way of review, a concept I talk about in other videos is that your blood pressure is determined by the combination of your cardiac output and your total peripheral resistance. And so if you know this, then it should be easy to understand that there are basically two ways a person can go into shock. The first way is if they develop low cardiac output. This could be because the left ventricle is not contracting normally, or it could be because there's very low intravascular volume, but either of these things will produce a low cardiac output, and that can produce a low blood pressure. And then the second way you can develop low blood pressure in shock is if there's peripheral vasodilation. And we'll talk about this later, but in some forms of shock, there's diffuse vasodilation that lowers the TPR, and that leads to a drop in blood pressure. Shown on this slide are the four major types of shock, and we'll go through all of these later in this video. So cardiogenic shock refers to a cardiac disorder where the left ventricle is not contracting normally, and this leads to a fall in cardiac output. Hypovolemic shock, as the name implies, refers to a fall in intravascular volume, and when there's not enough blood volume, there's going to be low cardiac output. And the classic cause of hypovolemic shock is hemorrhage, but there are other reasons why a person can just have low intravascular volume and therefore hypovolemic shock. Third form of shock is called distributive. This is the term that's used when there is diffuse peripheral vasodilation so that the TPR gets very, very low, leading to a fall in blood pressure. The classic cause of distributive shock is sepsis, but you can also see it from anaphylaxis and some other causes we'll talk about later. And then finally, there's a rare and sort of obscure form of shock called obstructive shock, which occurs in a couple of special scenarios, and we'll talk about this later in this video. When a person presents with low blood pressure and shock, it's important to figure out what type of shock they have. And that's because there are different treatments for the different types of shock. So a person with low intravascular volume who has shock could be treated with fluids, but a person who has cardiogenic shock needs to be treated differently because their problem is coming from the heart. So it matters what type of shock a patient has. Often this is obvious from history. So for example, if a patient comes in with a large anterior myocardial infarction and they become hypotensive and go into shock, this is pretty obviously a case of cardiogenic shock. On the other hand, if someone has massive bleeding after a motor vehicle accident, then that's most likely going to be hypovolemic shock. But if a person has shock and the etiology is unclear, we do have a test that can be used to determine the cause of the shock, and that's called using a Swan-Ganz catheter. So let's talk about that now. So a Swan-Ganz catheter is also called a pulmonary artery catheter, and it's a long tube that's threaded into the heart. So this is a picture of one here. The blue tube is the catheter, and you thread it through the right atrium, which is right here in this cartoon, the right ventricle here, the pulmonary artery, which is here. And as you're moving through these chambers, the tip of the catheter will measure the pressure. So as you insert this device into a patient, you can pause and measure their right atrial pressure, their right ventricular pressure, and their pulmonary artery pressure. And then finally, you can do something special, which is you push the catheter as far as it will go, and then you blow up a little balloon. This is shown here. I kind of blew the picture up for you so you can see it. When you do this, the tip of the catheter here is seeing the pressure beyond the balloon that's inflated. In other words, the balloon is blocking off the pulmonary artery blood and the pulmonary artery pressure, which is back here, and you're seeing the pressure that is beyond the inflated balloon. And that pressure is going to be essentially the same as the left atrial pressure. So we call this procedure a pulmonary capillary wedge procedure, and we call this measurement of the pulmonary capillary wedge pressure. And anytime you're measuring this pressure, you need to know that that's essentially equal to the left atrial pressure. So what this means is by inserting a Swan-Ganz catheter, you can measure the right atrial pressure, the right ventricular pressure, the pulmonary artery pressure, and you can also get an estimate of the left atrial pressure. It's indirect, but it's fairly accurate. And the pulmonary capillary wedge pressure will be essentially equal to the left atrial pressure. Shown on this slide are normal values for all the pressures that you can measure with a Swan-Ganz catheter. So the normal right atrial pressure is about 5. In the right ventricle, the pressure goes up to 20 in systole and down to 5 in diastole. Remember, these two pressures should be equal because the only thing between the right atrium and the right ventricle is the tricuspid valve, and assuming it's working normally, then you should have equal pressures between the right atrium and the right ventricle. The pulmonary artery pressure goes up to 20 in systole and down to about 10, and then the pulmonary capillary wedge pressure, normal value, is about 10. And then finally, there's a measurement you can make with the Swan-Ganz catheter called the mixed venous oxygen saturation. So what this refers to is taking a blood sample from the pulmonary artery. And when you do that, you're getting the oxygen saturation of that blood sample, which represents mixing of all the venous blood in the body. If we go back to this slide, when the catheter is here in the pulmonary artery, if you take a blood sample, that blood sample is basically all the blood from the venous system that has flowed into the right atrium here and then gone on through the right ventricle to the pulmonary artery. And we call that the mixed venous oxygen saturation. And as we'll see in a minute, that number is very helpful for determining how the heart is working in patients who have shock. So one of the reasons the mixed venous oxygen saturation is so helpful is because it varies with cardiac output. So when the cardiac output is very high, blood is moving quickly through tissue beds. There's less time for oxygen to be extracted, so that mixed venous oxygen saturation is going to be high anytime the cardiac output is high. Conversely, if there's a very low cardiac output, then blood is moving very slowly through tissue beds. This gives the tissue beds lots of time to extract oxygen, so the mixed venous oxygen saturation that person's body is going to have will also be low. And in most forms of shock, the mixed venous oxygen saturation is low. We'll talk more about this later. But this table, which I've shown on the bottom of the slide here, is very important for you to understand. Anytime they tell you that the mixed venous oxygen saturation is high, they're trying to tell you the cardiac output is high. Conversely, if the mixed venous saturation is low, they're trying to tell you the cardiac output is low. And that's for the reasons I just explained here. Not only does the mixed venous oxygen saturation give us an idea of whether the cardiac output is high or low, you can actually use that number to calculate an exact cardiac output for a patient. And in order to do that, you use the Fick equation. So let's talk about that now. So the Fick equation basically comes from the simple principle that the oxygen consumed by our body as a whole is equal to the oxygen in the blood that's coming out of the lungs, the fully oxygenated blood, minus the oxygen in the blood going into the lungs. So blood here just left the lungs and it's about to go out to the body. Blood here has had lots of oxygen extracted from all the tissue beds in the body. So this difference should equal the oxygen consumed. Well, it turns out that the oxygen out of the lungs is going to be equal to the cardiac output times the percent of blood that is oxygen. And the oxygen in the blood going into the lungs is also going to be equal to the cardiac output times the percent of oxygen in that blood that's entering the lungs. So we can write this equation like I've shown here. The cardiac output times the arterial oxygen concentration. This is the concentration of oxygen in arterial blood that has just left the lungs. It's this number right here, minus the venous oxygen concentration. And this is the mixed venous O2 that we just talked about. You can get this number from the Swan-Ganz catheter. And so if we rearrange this whole equation, we have that the cardiac output is equal to the oxygen consumed by the body divided by the arterial oxygen content minus the venous oxygen content. If this is the first time you're looking at this equation, take a second to think about this and make sure you understand it in your mind. Because once we have this equation, we can get all these numbers fairly easily. Oxygen consumption is proportional to body size, so there are tables where we can look up an estimate of the patient's oxygen consumption. The arterial oxygen content is very easy to obtain by using a finger probe that measures oxygen saturation. And then finally, the venous oxygen content is the mixed venous oxygen from a Swan-Ganz catheter. So putting all this annoying math that I've listed here together, the key point is what I've listed at the bottom of the slide, which is the Swan-Ganz catheter gives us the cardiac output because it gives us this oxygen content of venous blood. And once we have that, it's easy to get these other numbers and calculate an exact cardiac output for a patient. Once you know the patient's cardiac output from the Fick equation, you can then use the flow equation to determine a patient's systemic vascular resistance. So the flow equation says that the change in pressure as blood moves through the body is equal to the cardiac output times the systemic vascular resistance. Well, the change in pressure is the mean arterial pressure. So in someone who has a blood pressure of 120/80, you could calculate a mean arterial pressure, and then you subtract the right atrial pressure, which is usually a small number like 5 or 10 or so. That will be equal to the cardiac output times the SVR. And so if you rearrange it, then we now have an equation for the SVR. The cardiac output we got from the Fick equation. We saw that on the last slide. The mean arterial pressure you can get from measuring the patient's blood pressure in their arm. And the right atrial pressure we know from the Swan-Ganz catheter. We saw earlier how you can measure that. So the bottom line here, once again, the sort of take-home point of all this math I'm showing you is that using the Swan-Ganz catheter, we can get a patient's SVR. And remember, SVR and TPR mean the same thing. These two terms are used interchangeably. Some textbooks call it the systemic vascular resistance. Some call it the total peripheral resistance. They both mean the same thing. And you can calculate an actual number for these resistances with data you get from the Swan-Ganz catheter. So now we've got a full table of all the information we can get from a Swan-Ganz catheter here. We can get all the pressures I showed you before. We can get the mixed venous sat. And then from that, we can calculate the cardiac output and the systemic vascular resistance. Why am I going through all this math with you and telling you all these things? The reason I'm doing this is because all of these values here we're going to use to determine a patient's cause of shock. In other words, each of the 4 forms of shock I told you before has a profile in terms of the pressures and the mixed venous sat and the cardiac output and the SVR. And we're going to talk about in the rest of this video what those profiles are. So I first wanted you to understand where all these values come from. So getting back to the topic of this video, which is shock, there are 4 major classes of shock like I told you before. They're all listed right here. And each of them have different hemodynamics. That's what I said in the last slide. And by hemodynamics, I mean different pressures in the heart, different cardiac output, different SVR. And that's what we'll talk about in the rest of this video. So let's start with cardiogenic shock. So the hallmark of cardiogenic shock is low cardiac output with high cardiac pressures. So if you look at this little cartoon here, the problem in cardiogenic shock is that the left ventricle here is not contracting normally. This is the kind of shock that occurs in advanced heart failure or massive myocardial infarction. So when this chamber doesn't pump well enough, that's going to lead to low cardiac output. But also when it doesn't pump well, blood's not going to enter it normally from the left atrium. So the left atrium is going to fill with blood and the pressure in the left atrium is going to go up. Because the pressure is high in the left atrium, that's going to get transmitted backwards into the pulmonary capillaries and into the right ventricle and into the right atrium. So when a patient has cardiogenic shock, you see low cardiac output, but you also see high pressures when they're measured in the cardiac chambers. In addition, the SVR will be high. This is not caused directly by the cardiac problem, but it's the sympathetic nervous system's response. Whenever there's low cardiac output and low blood pressure, the sympathetic nervous system is activated. It constricts peripheral arterioles, and that raises the SVR. So this is the profile of cardiogenic shock: low cardiac output, high pressures, high SVR. Classic cause is large myocardial infarction, like I mentioned. You can also see it in advanced heart failure in patients who have severely depressed left ventricular ejection fractions. Okay, next let's talk about hypovolemic shock. So this is the form of shock that occurs when there's very low intravascular volume. So why could this happen to a person? Well, this could happen to someone who has very poor fluid intake, like someone who hasn't had access to water for days and days. People who have high fevers can sweat and they blow off lots of fluid as water vapor in their lungs. We call these insensible losses, and this could potentially lead to hypovolemic shock. And then, as I said earlier, hemorrhage is sort of the classic cause. Someone who loses a lot of blood from a trauma, that patient will develop hypovolemic shock. In terms of hemodynamics, the hallmark of hypovolemic shock is low cardiac output with low cardiac pressures. So just like in the patient with cardiogenic shock, the cardiac output is low, but this time it's low because there's low intravascular volume, not because the left ventricle isn't working. So this means that you're not going to get those high pressures in the heart like you saw with cardiogenic shock. You're going to have low pressures everywhere, including in the heart, because there's simply low volume throughout the body. And then finally, the SVR will be high, and that's because the sympathetic nervous system is responding to the low blood pressure and the low cardiac output. Okay, next form of shock is distributive shock. So the hallmark of this form of shock is low systemic vascular resistance. It's really the only form of shock where the SVR is low. This form of shock occurs when there's diffuse vasodilation or endothelial dysfunction. Something causes blood vessels and peripheral arterioles to massively dilate, and that lowers the SVR and lowers the blood pressure. The most common cause is sepsis. I talk about this in videos in the infectious disease section. But bacteria can induce an overwhelming response from the body. That's called sepsis, and there's diffuse vasodilation, and that leads to the low SVR of this form of distributive shock. You can also get vasodilation from anaphylaxis as an allergic reaction. Also, there is a form of distributive shock called neurogenic. This occurs when patients have spinal trauma and they damage their sympathetic nervous system nerves. This leads to loss of sympathetic innervation to parts of the body, and so there's vasodilation. In terms of hemodynamics, the most important thing to know about distributive shock is that the SVR will be low. That makes it different from all the other forms of shock. The other parts of the hemodynamics are tricky. So the cardiac output is classically high, although it's variable. Why is it high? It's high because when there's vasodilation and low SVR, the sympathetic nervous system makes the heart beat very hard and very fast. And so that can raise the cardiac output. But that doesn't always happen because sometimes these patients have lost intravascular volume. So that's why I say it's variable here. And you can't rely on the cardiac output to tell you that a patient has distributive shock. Same is true of the cardiac pressures, okay? They can be low or they can be normal. It depends on whether or not the patient has lost fluid volume. The bottom line is the one feature of distributive shock that is always present is the low SVR. So we'll talk about obstructive shock, the fourth form of shock, in a minute, but that's a relatively uncommon type of shock. Shown on this slide are the three major types of shock and their hemodynamic profiles. So first of all, blood pressure and heart rate are easy. Blood pressure is low and heart rate is high in all forms of shock. The heart rate is high because the sympathetic nervous system responds to the low blood pressure and tells the heart to beat faster. The right atrial pressure, the right ventricular pressure, and the wedge pressure are all high in cardiogenic shock, and that's really the only form where they're ever high. They're all low in hypovolemic shock, and then they're variable in distributive shock. They can be low or they can be normal. It depends on how much fluid has leaked out of the person's vasculature. For example, in septic shock, the blood vessels become leaky and the patient loses intravascular volume. If they haven't lost much volume, they can have normal pressures. If they've lost a lot of volume, they can have low pressures. The cardiac output is low in cardiogenic shock, low in hypovolemic shock, and it's low or normal in distributive shock. It depends on, once again, whether or not the patient has lost a lot of intravascular fluid. And then finally, the SVR, remember, if they tell you it's low, they're talking about distributive shock. That's the only form of shock with low SVR. Otherwise, it's high in cardiogenic shock and high in hypovolemic shock. And here's a table showing a flow chart, which is basically what I go through in my head when I'm looking at hemodynamics and trying to decide on the form of shock the patient has. I usually look at the SVR first. That's just my way of doing it, because if it's low, you know it's distributive shock. If the SVR is high, then you've got to look at the cardiac pressures, all right? If they're high, it's cardiogenic shock. If they're low, it's hypovolemic shock. The physical exam can give you some clues to the type of shock the patient has and their hemodynamics. And this is especially important, critically important for board questions, because they will describe these findings and want you to understand what they mean in terms of the hemodynamics of shock. So first of all, cold skin is a sign of very high SVR and low cardiac output. All right, when the SVR gets very high, there's less delivery of blood to the skin, so that can make it cold. And then if the cardiac output is also low, then you're definitely going to get cold skin. So you can see cold skin in cardiogenic shock and hypovolemic shock for these reasons here. On the other hand, if they tell you the patient has warm skin, that often means low SVR and high cardiac output. When the SVR gets low from distributive shock, it's very easy for blood to flow to the skin, so the skin can become warm, especially if the cardiac output is also high. So when you see warm skin and they're describing a patient in shock, you want to think of distributive shock. The jugular venous pressure, which I talk about in heart failure videos, you can estimate this from physical exam. It's a measurement of essentially the right atrial pressure, because the pressure in the jugular veins is the same as the pressure in the right atrium. So if they tell you this pressure is up, then they're telling you the right atrial pressure is up, like what you would see in cardiogenic shock. And then when pulmonary rales are present, it's super high yield to know that always means high left atrial pressure. When the left atrial pressure gets high, that pressure is transmitted backwards to the capillaries in the lungs, and that drives fluid out into the lung tissue, and that's what gives you pulmonary edema and pulmonary rales on physical exam. So once again, if rales are present, they're telling you high left atrial pressure is present, and that's what you expect in cardiogenic shock. Okay, now let's talk about that fourth form of shock, that uncommon form of shock, and that is obstructive shock. So obstructive shock gets its name because there's obstruction to blood flow from the heart to the body. Patients with this condition will have a low cardiac output, but they don't have a problem with the left ventricle. They have normal contractility. That makes this different than cardiogenic shock. And there are basically three conditions that lead to obstructive shock. One is cardiac tamponade, second is tension pneumothorax, and the third is massive pulmonary embolism. And I'll talk about all these in the next few slides. But no matter which one of these is causing the problem, in terms of hemodynamics, all these forms of obstructive shock lead to a low cardiac output with a high SVR. Remember that the SVR should always be high in shock, with the one exception of distributive shock. So attention pneumothorax is a condition I talk about in more detail in videos in the pulmonary section. But by way of quick review, a pneumothorax means that there is air in the pleural space inside the chest. An attention pneumothorax is a special type of pneumothorax where the pressure is getting so high inside the chest that it can compress veins. And that's what happens in attention pneumothorax. Intrathoracic veins become compressed by all that gas trapped inside the chest. When this happens, there's going to be decreased venous return. Basically, the veins are being smushed and they're not able to allow blood to flow through them and back into the heart. With less venous return, there's going to be a fall in cardiac output, and this is what leads to obstructive shock. And when you decompress the lungs, when you put in a needle and you let the air come out of the rib cage, this will restore the venous return and bring the cardiac output back up. I talk about cardiac tamponade in the video on pericardial diseases, but by way of review, it occurs when there's a large pericardial effusion that compresses the ventricles. Basically, pericardial effusion, which is fluid surrounding the heart, if the pressure in that pericardial space gets high, then it will impair the relaxation and filling of the right and left ventricle. When this happens, the left ventricle is going to underfill. This means there's going to be decreased preload. With less preload, there's less stroke volume and cardiac output, and that's what leads to obstructive shock. And when you put in a needle and drain the fluid from the pericardial space, that restores LV filling, the stroke volume and the cardiac output go back up, and the patient comes out of shock. And then the third cause of obstructive shock is a massive pulmonary embolism. This is another topic that I discuss in the pulmonary section. But when there's a blood clot in the pulmonary arteries and the blood clot is very large, the blood clot will obstruct flow through the pulmonary arteries to the lungs and to the left side of the heart. This is going to lead to impaired filling of the left ventricle. With impaired filling, there's less preload, less stroke volume and cardiac output, and that's what leads to shock. And if you give the patient a lytic to break up the clot that's obstructing blood flow, that will restore LV filling and can reverse the shock. This is a CT scan here showing a massive pulmonary embolism. Just by way of review, this is the ascending aorta here, the descending aorta here. This is the pulmonary artery here. It's bifurcating, going to one side this way and one side that way. But all this dark material here is blood clot. And so when you see a lot of blood clot like that covering the branching of the pulmonary artery, we call that a saddle embolism. And that's what this patient has. This is a massive pulmonary embolism. Person who has this CT scan is very likely to be in shock. So like I mentioned earlier in the video, the treatment of shock depends on the type of shock. So patients who have cardiogenic shock usually need inotrope drugs. I talk about these drugs in other videos, but these are drugs like milrinone and dobutamine, and they make the left ventricle contract more vigorously. Patients with hypovolemic shock need volume, so they need blood transfusions or IV fluids. This is the treatment of hypovolemic shock. The treatment for distributive shock is vasopressors. So these are drugs like phenylephrine or epinephrine or norepinephrine. They're vasoconstrictors, so they raise the SVR because remember, low SVR is the problem in distributive shock. Now, one thing to be aware of is when you give vasoconstrictors, that increases the afterload on the left ventricle. So this can reduce the cardiac output if fluids are not given. And so for this reason, the mainstay of treating distributive shock like septic shock is to give IV fluids and then use pressors. And the idea here is that the fluids are keeping the cardiac output up and the pressures in the heart up, and the pressors, the vasopressors, are raising the SVR. And then finally, in obstructive shock, the treatment depends on what's causing the obstruction. You need to either treat the tamponade, the pulmonary embolism, or the tension pneumo, like I talked about in the last few slides. And then finally, I'm going to finish with 2 slides just talking about how you can use the numbers you get from the Swan-Ganz catheter to make a diagnosis of valvular heart disease in addition to shock. I talk about valve disease in another video, but for example, a board question might show you these hemodynamics here and ask what's going on. And so if you look closely at these numbers, you can see that we have a wedge pressure of 30. That's very high, much higher than the normal value of 10. And then we have a left ventricular diastolic pressure of 5, which is lower than the normal value of 10. This difference here, this 25 millimeter difference between the wedge pressure and the left ventricular diastolic pressure, should not exist in a normal patient. Normally, the wedge and the left ventricular diastolic pressure are very close to one another, essentially equal. What we have here is a gradient between the left atrium and the left ventricle. And what structure sits between the left atrium and the left ventricle? The mitral valve. So these numbers here are what you would expect to see in mitral stenosis. And so I'm showing them to you now so that when you're looking at these hemodynamics and board questions, make sure to look at the pressures and see that the pressures that should be equal, like these two here, and these two here are equal. If they're not, there's a gradient and there's something going on. And then just one more example before we finish the video. If you look at these numbers, we have a left ventricular systolic pressure of 150, which is much higher than the normal of 120. And then we have a normal aortic systolic pressure. So the left ventricle pushes blood into the aorta during systole, and we have a 30 millimeter difference between the two pressures. Well, what is in between the left ventricle and the aorta? Well, first of all, the aortic valve. So these are the type of hemodynamic values you could get in aortic stenosis. You can also see these in hypertrophic cardiomyopathy. In that situation, it's not the aortic valve obstructing flow from the left ventricle to the aorta. It's actually the thickened myocardium. And I talk about that in its own video. So I just show you these so that you understand that the pressures you get from a Swan-Ganz catheter can be used to diagnose shock. They can also be used to characterize valvular heart disease. And that concludes our module on shock.